We'll wait for a few more minutes.
ஓகேங்க சார், ஓகேங்க சார்.
Loganathan, good evening.
Sir, good afternoon, sir. I'm in line, sir.
Yeah, please. We'll just wait for a few minutes, Loganathan.
Yes, sir. Yes, sir. We are waiting.
Murali, we can start. Huh?
Yes, sir. Please, sir.
Good evening to one and all. I'm Dr. Sumaran. I'm the Dean and Director of Sri Ramakrishna Hospital. I welcome all the consultants from inside and outside Ramakrishna Hospital and all the doctors from the city of Coimbatore to this webinar organized in a series for the last 2.5 years. And today's speakers are Dr. M. Murugesh, medical gastroenterologist. He's a senior gastroenterologist in the city, and he's so much experienced in all the interventional procedures like endoscopies and colonoscopy and ERCP, and he has gained a name in the city as one of the best ERCP technologists in the city. And he is going to talk about the recent advances in endoscopy today. And I think the topic will be useful to most of the doctors, and I hope it will be a very sweet session. And the next speaker is our well-known pulmonologist, Dr. Loganathan, and who has done his MD General Medicine and DM in Pulmonary Critical Care and Sleep Medicine from All India Institute of Medical Sciences. And after his joining in Sri Ramakrishna Hospital, the pulmonology department has developed very well, and his role in the COVID season was commendable. And both these consultants are actually gifts to Sri Ramakrishna Hospital. And Dr. Loganathan is going to talk about difficult to treat asthma. I mean, even the topic, I was thinking about the topic, whether asthma is difficult to treat or which asthma is difficult to treat. So like that, there were two meanings. And I thought he's going to talk about the asthma, which is which is difficult to treat. I welcome both the speakers, and I thank them for sparing their time in spite of their commitments daily. And I welcome Dr. Murugesh to take the stage. Thank you.
Good evening to one and all. Thank you, sir, for your wonderful introduction. First of all, I thank hospital management, CEO, Dean, and other supporting staff for organizing this wonderful meeting. Respected senior doctors in the city, colleagues, and friends. I am Dr. Murugesh, consultant gastroenterologist, working in the Department of Gastroenterology in Ramakrishna Hospital, almost since 2012, almost a decade. Today's talk is never gastrointestinal endoscopic procedures. I'm not going to talk about much in depth about all the detailed procedures, all these things. Just I will give overview about what are the latest innovations in the Department of Gastroenterology, and newer advances and newer equipments and newer procedures, and what are the procedures been done in our hospital. I'll show you a short video of each cases. Rather than I'm going to present a lecture, I'll take in a 6-7 important cases with video clips. Just I'll share you with all these interesting cases. I hope you all enjoy. So this is the elderly male. Is a 65-year male. Is a non-diabetic hypertension and had severe cerebrovascular accident recently. Then he is put on aspirin, clopidogrel, and supportive medications. This patient presented with massive upper GI bleed. When the patient came to our hospital, he was pale, had mild tachypnea was there, tachycardia was there because of volume loss. And clinically, patient abdomen was soft, no guarding rigidity. As per the protocol of upper GI bleed, patient was initially stabilized with fluids, pantoprazole infusion, vitamin K, Trenaxan, blood transfusion, and the hemodynamic stability. Once patient was stable, actually we are taken for upper GI endoscopic procedures. When we did endoscopy, actually we have seen large ulcer in the anterior wall of the duodenum with active bleeding. What next you want to do? When you want to continue medical management, most of the time when you see a large ulcer in the anterior duodenum, most of the time patient will do well with conservative management, fluids, blood transfusion, PP infusion, all these things. But still some patient they go for further GA bleed. Then we can try injection therapy. Previously we used to inject saline adrenaline. The saline is just got tamponade effect, adrenaline which produces some vasoconstriction. And then some patients with this management they'll do well. But still the patient bleeds, we can go for organ plasma coagulation and gold probe. The recent innovation in the field of gastroenterology is Ovesco clips. Just I'll show the what is it. You can see this is a patient present with upper GI bleed. This is an endoscopy short video. You can see the active bleeding in the duodenum first part. You can see the gush of blood coming from the first part of the duodenum. So this is what we did for this patient. Actually, this clip was mounted over the endoscope. You can see these are the clips. This is what we call is OTC. That is means over the scope clips. That is company name is Ovesco. This was which was mounted over the tip of the montoscope. Then we are introducing into the duodenum. Then you can see this clip was nicely. This is a post procedure. You can see the clips with 4 arms. One is in the right side 2, then left side 2. Everything is deployed nicely. You can see there is no more bleeding. Actually, this is a very good device which has been devised and actually very effective in managing the bleed. Otherwise, this kind of patient will most of the time end up in surgery. With this, we can avoid major surgical interventions. Similar, these scopes can be used for fistulas and perforations of GI tract. We can close the fistulas and perforations. Coming to the next case is a 75-year-old male admitted with history of bleeding per rectum. Coloscopy showed flat polypoidal lesion. The biopsy was taken which showed adenoma with moderate to high-grade dysplasia. Then what want to do for this patient? When you want to subject this patient for simple polypectomy, EMR or ESD. Polypectomy is have patient with small polyp or pedunculated polyp, we can do endoscopy polypectomy. Endoscopic mucosal resection can be done, or with more advanced in technology, we can go for endoscopic submucosal dissection in view of high-grade dysplasia. So this is the coloscopic picture. You can see one flat lesion. Actually, you can see that there is still some oozing of blood in the polypoidal lesion. Actually, this is the endoscopic submucosal dissection short video. Actually, we have to inject the saline into the submucosal space. We have to elevate the lesion. Before that, you have to mark the lesion with diathermy so that you know where to dissect and where to start and where to end. Then after marking the lesion, actually we are using some knife, that is special knife, which is designed mainly for endoscopic submucosal dissection, and you can start dissecting. Can you see? You can see the these are the dual knife. Here is used for same both for injection and dissecting the lesion. During dissection, sometimes we may develop some bleeding that can be easily managed with a lot of equipments available. That what is called is coag grasper. Actually, half the lesion has been dissected out. You can see we are just lifting the lesion. Then some oozing was there, but with this oozing, or we washed with the saline. Then still further bleed means we can have to use some clips and quiet grasper to control the bleeding.
Mm. Mm.
So actually, almost the dissection is completed. We can see whole this polypoidal lesion has been removed. Then only we are seeing is a submucosal part of the intestine. There's some blood, minimal oozing with blood clot was there, which has stopped almost without much intervention. These are post procedure. You can see some defect is there. There is no complication except minor bleed. There is no perforation. Nothing else is there. Patient was kept NPO for 24 hours. After 24 hours, patient was started oral feeding. Then patient was discharged 2 days later. This is yet another case. Actually, is a 70-year-old female presented with history of jaundice. Means cholestatic jaundice means obstructive jaundice. Then ultrasound abdomen showed large, large means 1.5 centimeter calculi in the mid CBD. What is DACE? DACE means dilatation assisted stone extraction. Normally, with ERCP, we can remove small stones 0.5 to 1 centimeter without much difficulty. When stone is more than 1.5 centimeter, with the lower CVD is narrowed, we have to go for some different mode of treatment. Actually, this patient underwent ERCP elsewhere outside the city. Actually, they could not remove the stone. Actually, they referred here for further management. Actually, this already, you can see this patient already the sphincterotomy was done. Then you can see one, this is already sphincterotomy done. I am passing the catheter and cannula inside the CVD. This you can see some diverticula in the near the ampulla. So once is the catheter guide wire is deep into the CVD, you can see some flow of bile from the duct. Actually, what we are using is the CRE balloon. CRE means controlled radial expansion balloon. We can this used to do sphincteroplasty. That means to dilate the common bile duct. Because when you do wide sphincterotomy, you may end up in perforation because of very close fistulas around. You can see as the balloon is we are inflating, you can see the stone is popping out from the orifice. You can see this is a large stone which is easily retrieved without much difficulty with a simple CRE balloon. That is what we use is controlled radial expansion balloon. There is the procedure is called DACE, dilatation assisted stone extraction. One stone was removed. Actually, the other small debris, everything is retrieved with a simple balloon. This stent was placed. This yet another case is a 75-year-old male. Again, this male presented with obstructive jaundice. Then MRCP showed large 2 centimeter mid CVD calculi with narrowed lower CVD. When you have a large stone in the mid or proximal CVD with narrowed lower CVD, very difficult to retrieve with either stone extraction balloon or CRE balloon. Previously, I have shown this case, or any lithotriptych basket. What we did is ERCP with spyglass cholangioscopy. Spyglass cholangioscopy means actually we are directly entering into the CBD and visualizing the stone. And this is the SPY DS. Actually, it is innovated by Boston Scientific. You can see this is the SPY scope. Actually, we are entered into the common bile. You can see the large stone in the proximal CVD. We are using the holmium laser to break the stone into the multiple fragments. With this holmium laser, we fragmented the large stone into the small stones. You can see the laser which we are used to break the stones. One stone, everything is fragmented. You can see almost stones, everything is fragmented. Then once stones, everything is fragmented, then these small stones can be easily retrieved using a routine stone extraction balloon or basket. Actually, what we use is the holmium laser. Can you see all the stones has been almost fragmented? These are fragmented stones were there, which can be easily retrieved using stone extraction balloon. Spyglass cholangioscopy means directly we are visualizing into the CVD, or we can do some pancreatic interventions also. Sometimes any migrated pancreatic stents, even CVD stents, we can do some diagnostic procedure. Any cholangiocarcinoma, we can do biopsy also. This is one interesting case is a 85-year-old male presented with pneumochuria. Pneumochuria means passing air in the urine with fecal material on and off. And actually this patient presented with pneumochuria with abdominal pain, fever and rigor because of urinary infection. What is it? Actually, the case of colovesical fistula. Actually, patient was evaluated and diagnosed to have colovesical fistula with multiple sigmoid colon and descending colon diverticulum. What next? Actually, the case of colovesical fistula with recurrent urinary infection. Standard of care for this kind of patient is surgery because the 85-year-old male and surgery is got more morbidity and post-operative all the complications, everything. Then medical management means we can treat this patient with antibiotic supportive care. That is only give some temporary relief from the urinary infection. That fistula persists, again patient will develop similar recurrent UTI. This patient is subjected to colonoscopy. Colonoscopy showed multiple diverticular in the sigmoid colon, descending colon with suspicious fistula with multiple diverticula nearby. This is the colonoscopy image. You can see there is a one diverticula. You can see there are multiple diverticulas here and there. You can see that these are multiple diverticulas are there. So in this case, actually, when the patient is present with colovesical fistula and multiple diverticula, means we don't know which diverticula is connecting into the bladder. So what we did is one combined procedure. One is with urologist, our colleague Dr. Ganesh Prasad. He did a ureteroscopy examination. Then he identified the fistula from the bladder side, and he passed a guide wire into the colon. Actually, you can see actually this is the guide wire. Actually, it has been passed into the colon from the bladder side. Actually, from colon side, actually we have multiple diverticula is there. When we enter into the urinary bladder, we can see only single fistula. From that fistula part, actually the guide wire is passed into the colon. So that means there is the entry point. That is the where there is a fistulous connection between the sigmoid colon and the bladder. So with that site, actually we use the clip called Osco clip, but the same clip which was used to control the bleed. Actually, this is the fistula site. Actually, this is the guide wire is there. Once we reach the site, actually we retrieve the guide wire from the bladder side. Actually, this is the one grasper to hold the tissue into the device. You can see that actually we are using the grasper to pull the mucosa into the device. After that, we are just deploying the device. So you can see that this clip is nicely approximating around the fistula site. So this is the after that deployment, we can see the grasper. We are removing the grasper. This is the post procedure. We removed the applicator device, everything. With again we did the colonoscopy examination. There you can see the clip is nicely deployed. Actually, the patient was asymptomatic almost since more than 2.5 years. Actually, this kind of case, actually one case is published in Spine just 2 months prior to our case. Actually, we did in India as a first case. We published this case in journal. It has been accepted. Actually, it was published in Journal of Digestive Endoscopy. This yet another case. Actually, is a 18-year-old male presented with acute pancreatitis following COVID. We don't know whether COVID directly caused pancreatitis, but he had pancreatitis, which was treated considerably with fluids and as a standard management. 2 months later of pancreatitis, patient presented again with abdominal pain, fever, and abdominal distension. Patient was evaluated and found to have pancreatic pseudocyst. So what do you want to do with this kind of patient? Initially, pancreatitis was treated with conservative management. 2 months later, patient presented with pancreatic pseudocyst, which was infected. Conservative management means we can give antibiotics, supportive care, and patient had persistent fever. Then we consider surgical intervention or ultrasound guided drainage. Finally, this patient underwent endoscopic ultrasound guided heart oxygen stent placement because I had a lot of solid component along with liquid components. And in the patient with purely pseudocyst with predominantly fluid component means we can do either US guided drainage or ultrasound drainage. We can put a simple stent because in this patient had lot of solid component. You put a heart axis, actually it's a metallic stent. We deployed through the endoscopic ultrasound. After that, actually we did one chemical necrosectomy. Chemical necrosectomy means actually we placed a nasobiliary drain into the pseudocyst. Then almost 1 week morning and twice daily, morning and night, we instilled hydrogen peroxide into the this solid component through the NBD drain. Actually, after 1 week, actually almost all the solid component is dissolved and patient is better, no fever, no abdominal pain, patient discharged. After 1 month, we removed the stent itself. This is the last case, an elderly woman presented with bleeding per rectum. This is the colonoscopy. You can see one large pedunculated polyp and another one. This is one. Actually, this is a large peduncular polyp. Actually, this we crossed that one. This is a large another broad-based polyp was there. Actually, this peduncular polyp was we did polypectomy and biopsy from the broad-based polyp showed adenomatous polyp with high-grade dysplasia. So one recent advances in endoscopy is endoscopy full thickness resection. Any polyp with high-grade dysplasia with broad-based and lesion, if it is less than 2 to 3 centimeter, we can do full thickness resection through endoscopically. Actually, we had to, before subjecting for full thickness resection, we had to do debulking measures, remove the top of the polyp with using standard polypectomy method. Then after that, the site was marked with diathermy. This is a applicator. This is actually FTR device which was mounted over the colonoscope. Actually, we enter into the colon. Similarly, what we deployed for the case of colovesical fistula, we deployed the device. Actually, this is a different device which actually resects almost entire from mucosa, submucosa into the even the serous also. What happens after 3 months of this full thickness resection? Actually, this patient is still on follow-up. We did a colonoscopy 3 months later. You can see actually there is no residual lesion, there is no clip also. This is a ridge. Actually, this is just like a post-surgical scar. Actually, almost this or mini surgery was done purely through endoscopic technique that is called endoscopic full thickness resection. This can be done for any lesion or early high-grade dysplasia, even carcinoma in situ. That lesion should be at least less than 3 centimeter. Any lesion more than 4 centimeter or 3 centimeter very difficult to resect because of the applicator device. Everything is designed for only 3 centimeter. Beyond that thing, actually, we don't have much wider clips at present. These are post 3 months later, the colonoscopy picture. Almost you can see there is no residual lesion. Actually, this patient came even after 6 months or 1 year also. Actually, there is no residual lesions in this case. Actually, patient is doing well. With these advances in the newer endoscopy procedures, we can avoid major surgical interventions. This FTR, what I said is 3 to 4 centimeter colonic lesions and 1 to 2 centimeter upper GL lesions, especially dysplastic lesions or carcinoma in situ or neuroendocrine tumor can be resected without much complications. Thank you all.
Thank you, Dr. Murugesh. I think I request Dr. Loganathan to.
Thank you, sir. Thank you.
Questions we'll have it at the end.
Okay, sir.
How to go? Present renew பண்ணல. Present பண்ணணும் சார். அதுல present பண்ணணும் சார். ஒரு நிமிஷம். கேமரா ஆன் பண்ண ஒரு நிமிஷம்.
Sir, good evening, sir.
Good evening, Loganathan.
Sir, my slide is visible, sir.
Yeah, please.
Yes, sir. Good evening to all of you, and I welcome all the doctors inside the Ramakrishna Hospital and outside the Ramakrishna Hospital for our weekly webinar talk. And we had a nice lecture from Dr. Murugesh sir sometime before, short while ago. And I thank our beloved Dean and Director sir for the nice introduction and the support all the time he gives to us. And thanks a lot, sir. So with this, I start the assigned talk today, that is on difficult to treat asthma. And our Dean sir was telling initially, asthma, is it difficult to treat, or is it made too difficult to treat asthma? And I'm sure at the end of the presentation, we'll come to know what is difficult to treat asthma and what is severe asthma and so on. So I specifically will assign my time to explain what are situations that we face this difficult to treat asthma. So if you look at the asthma, asthma is a chronic inflammatory disease which has the episodic symptoms and diurnal variation symptoms, and it has mild, moderate, and severe category with different steps of management in every aspect. So the treatment is based on, you assess whether this patient has asthma or not, you adjust the medications, and you review the response, whether this patient is responding to treatment or not on follow-up. So you look for symptoms, you look for exacerbations, you look for side effects, and also lung function, and whether the patient is satisfied or not. And you confirm the diagnosis, of course, before you starting the treatment. You assess the symptom control with specific questionnaire. You look for modified risk factors, and you look for comorbidities and treat them. And the most important is to look into the inhaler technique and adherence to the medications whichever you are prescribed, and to look into the patient goals. These are very important. And the most important point is, to look into the inhaler technique and adherence in those patients, asthma, you prescribe the inhaler therapy, which is the cornerstone of management of this chronic inflammatory disease. And world over, not only here, not only in Coimbatore, not only in Tamil Nadu, not only in India, and all over the world, the most commonest problem, challenging task in patient with asthma is to educate and to follow them up for a proper inhaler technique and adherence. And this cannot be overemphasized. That is a problem everywhere in this world, and we continue to share our problems in every conferences, whether it is regional, local, or international or national. And there are two types of treatment in asthma. You give controller therapy for long-term control. You give reliever therapy for short-term control. You have step 1 to step 5 treatment in patients with asthma, depending on the severity. I will not go into those details. So what is the goal of asthma management? You need to have a symptom control. It's very important. Patients should have a few asthma symptoms, no sleep disturbance, and no exercise limitation. This is the goal in patients with asthma. And at the same time, controlling the symptom, you always reduce the risk and of exacerbation. How to do a risk reduction in patients with asthma is to maintain normal lung function. You have a patient with asthma with a normal lung function. You have a patient with asthma with poor lung function. A patient with poor lung function is not a good candidate at all for you on long term, because they are prone for the exacerbation later on. So you have to prevent the flare-ups, that is exacerbations, and you prevent asthma deaths, and you avoid asthma medications related side effects. So these are the two important goals in patients with asthma management, that is symptom control and risk reduction. And going into the terminology, what is uncontrolled asthma? Uncontrolled asthma is a patient with asthma with frequent symptoms or flare-ups. You have poor symptom control, and many of these patients may potentially have a mild asthma, that is their asthma could be well controlled with low dose ICS, but if even then it is uncontrolled, and there is frequent exacerbations or serious exacerbations. So if you have a poor symptom control, flare-up, poor symptom exacerbations, and serious exacerbations, frequent admissions, you call that patient having uncontrolled asthma. And coming to the topic today, what is difficult to control asthma, difficult to treat asthma? Not difficult patients. Our dean sir was telling initially, is it difficult to treat? No, not difficult to treat patients. And what it is difficult to treat asthma is an asthma which is uncontrolled despite prescribing high dose preventer treatment, despite GINA step 4-5 therapy, or that requires a such treatment to maintain a symptom control. What it essentially means is to look into the contributory factors that include incorrect diagnosis, incorrect inhaler technique, poor adherence, comorbidities, and smoking, etc. and etc. I'll be showing few of my patients on this category. And what is severe asthma? And what is the difference between difficult to treat asthma and severe asthma? Is an asthma which is uncontrolled despite maximal optimized therapy. This is very important. And treatment of contributory factors. In severe asthma, you treat the contributory factors, you optimize the therapy, which you don't do in difficult to treat asthma. So the terminologies in asthma are different with different meaning. It's like, you have a patient with unstable angina, you have Brandwald classification, class 1 unstable angina, class 2 unstable angina, class 3 unstable angina. The meaning are different. The what it tells is different. So likewise, the terminologies like uncontrolled asthma, difficult to treat asthma, and difficult to control asthma, severe asthma are different. So this is, the Halder's the diagram which my mentor, Professor Randeep Guler, likes a lot for so many decades. This small slide, but describes what is happening in asthma in nutshell. You have this y-axis, you have symptoms, you have inflammation here. And if the inflammation rises, if the patient has symptoms approximating to the inflammatory markers rise, you call it as concordant disease. You have less inflammation, more symptoms, you call this patient has discordant symptoms. So inflammation predominant are late onset, greater proportion in males, few daily symptoms with active eosinophilic inflammation. What it means in patient management day to day, if you look at the inflammatory markers, depending on that, you target anti-inflammatory therapy here, whether this patient has concordant inflammation or discordant inflammation. And on the contrary, what is the asthma patient who has symptoms with less inflammation are more obese, female preponderance, and late onset with high symptoms with frequent exacerbations. You have less strategies of asthma management medications in this group. So likewise, you have a patient with inflammation more, symptoms more. You have symptoms more, inflammation less, and on opposite side. So this is very important to understand what is happening in asthma airway biology. So how common is it, severe asthma? Yes, it is common. Look at the data. It is 24% of patients are the difficult to treat asthma or severe asthma. In that group, 17% are difficult to treat asthma. Asthma is a very common disease, like you have the COPD, coronary artery disease, or cancer. So asthma leading cause of death in this world. And among those, 17% is a huge number, considering the denominator of the asthma prevalence all over the world. And among the difficult to treat asthma, 3.4% are severe asthma. So by this, the data, you come to know, you might be knowing what is the difference between difficult to treat asthma and severe asthma. Actually, difficult to treat asthma are not difficult to treat asthma, provided you look into the factors which contributes that. So what are the factors to consider or to look into alternative diagnosis? So we would have listened to the medical school teaching that all wheezes are not asthma. So alternative diagnosis should be looked into in a patient whom you are labeled as asthma and not responding to the medications which you are given. Non-compliance to therapy is very important. Poor technique is very important. Environmental factors, looking at the upper airway problem, infection, gastroesophageal reflux diseases. In fact, we have some of our cross-reference patients with Dr. Murugesh, patients who have had asthma not controlled. If you look at the GI problem, they might be having huge hiatus hernia. If you look at those factors, these patients are improving and becoming off medications later on. Corticosteroid resistance, newer approaches, and so on. So all that wheezes are not asthma. So always, if a patient in a given patient, if you're not reaching a diagnosis, better to go for the patient the bedside again, ask for history, and if you don't get the diagnosis, again to go to the bedside again to ask for history, and even then if you don't get the diagnosis, please go to the bedside again and ask for history. These are not my words. These are the words of former, the medical, the director of medical education, Dr. Mohan Sundar, my professor of pharmacology. This was his first, the talk when we entered medical schools 20 years ago. So, what are the alternate diagnoses that you look into? Are COPD, vocal cord dysfunction, hyperventilation, cardiac disease, allergic bronchopulmonary aspergillosis, endobronchial obstruction, stress, anxiety, and so on. So, the list is not small; it's a very large list. But I'm projecting these because it's very common. So any patient who has a chest pain does not mean that this patient has acute myocardial infarction. Any patient who has an abdominal pain does not mean that this patient has pancreatitis. So you have various differential diagnosis, and that's what we mean by the title of today's my presentation. So the most important thing is to confirm the diagnosis, whether it is asthma or you have asthma-like symptoms with a differential diagnosis is the primary point in any patient. That not only holds good for asthma, it holds good for any disease in medicine. The patient is not improving, at least you have to check whether diagnosis is correct. If your diagnosis is correct, go to the other steps where you have gone wrong. So there is difficulty in confirming the diagnosis of asthma as the first step that one should look into, and other factors. Look at the frequent. Is there any frequent urgent healthcare utilization? Whether the patient is on oral corticosteroids, occupational asthma, and so on. Look at the other factors which can contribute to the exacerbation. So this 35-year-old lady came to us with a history of shortness of breath of 3 years duration and had a history of wheezing. This patient went to a doctor and treated with bronchodilators, steroids, partial response, no improvement. So this patient was put on step 1, 2, 3, 4, 5, and there are no beyond 5 steps in renal, put on high oral steroids with steroid side effects, became steroid dependent, and later came to us. Simple thing is diagnosis. That's what we teach our students. This patient underwent a pulmonary function test that itself gave the diagnosis. So in pulmonary function test, you not only look into the values, it is very important to look into the diagram per se, flow, volume, low. It itself is talks nowadays, previously also in conferences, what is the role of these volume time curve and flow volume time curve. Okay. So if you look at this flow volume curve, there is inspiratory and expiratory flattening, which suggests, there is fixed airway obstruction. So it itself gives the diagnosis, airway is obstructed. Go to the history again, as we talked sometime before, that this patient had history of surgery for ruptured ectopic pregnancy 4 years before and was put on ventilator. And on examination, this patient had monophonic wheeze. PFT showed this important finding, and that's where the diagnosis lies. It's a fixed stenosis at the lower end of trachea. It's a tracheal stenosis, fixed obstruction, presented with wheeze. It's not asthma, it is tracheal stenosis, anatomical problem that caused symptoms and not responded to treatment. Difficult to treat asthma, not difficult to treat asthma because the diagnosis is wrong. This patient underwent surgery, became better off medications. So this is the, if you look at the factors here, the severe obstruction that, and you, based on the obstruction, you cannot diagnose that this patient has asthma. All ST elevation in ECG are not ST elevation myocardial infarction. This patient have, the hyperkalemia, you can have pericarditis, you can have, all sorts of problems. There are many differential diagnoses for ST elevation myocardial infarction. All the obstruction are not asthma. It can be something else, especially in a patient in whom the medications which you are given scientifically are not working. This is one of our other patients who came with wheezing, not responded, became sick on outpatient evaluation, went to pulmonary function test, fixed obstruction. It is tracheal stenosis. This patient was shifted immediately to dilatation of upper airway obstruction. The did not respond. The surgeon took the patient for emergency tracheal resection surgery. You can see the ring like C-like structure, tracheal ring, stenosed, and this is a resected specimen. For unfortunate thing, this video is not working, but believe me, this patient underwent tracheal resection and anastomosis. You can see the sutures there. It was subglottic stenosis, presented with wheezing, treated as severe asthma, not responded. Differential diagnosis is different, improved after surgical correction. So look at this patient, 35-year-old housewife, presented to us with history of breathlessness of 1 day duration, dry cough, wheezing on and off for 6 months, episodic, seasonal, hemoptysis 3 months before. Any patient who was labeled as asthma, if the patient has progressive breathlessness, means something else, and hemoptysis should not be there in a patient with asthma. So that itself gives you that this patient has something else. This patient was diagnosed as asthma, who responds to drugs, evaluated for allergic bronchopulmonary aspergillosis, subsequently was given ATT because those are the days gone where white shadows in X-ray are tuberculosis. If you look at the textbook or any article on pulmonology all over, so many years before and down the line, majority of the diseases presents with white shadows in X-ray and CT scan. That does not mean that this patient has tuberculosis. So this patient underwent ATT trial with no response. The bottom line is we need to find out what is the differential diagnosis for that white shadow. This is different in this case. Was given high dose oral steroids and low oral steroids, thinking that it is difficult to treat asthma, and there were audible wheeze, and the patient entered into the outpatient department. This is an X-ray, and I'm sure that Gus on the forum today might be curious to say and to see that might be a deceptively looking normal X-ray, but actually this is not deceptively looking normal X-ray. We approximate the investigations which we ask in medicine depending on the history. Look at the lower trachea, there is complete opacification. So on the outpatient department itself, there was lower tracheal lesion. I don't know whether one can appreciate here, maybe poor projection here, but believe me, there is lower tracheal obstruction. The right main bronchus, left main bronchus, something is sitting there. So this patient underwent CT. This is the mediastinal window cut. Lower trachea, you can see projection close to the carina. It was a growth there. Unfortunately, this patient is a relative of a doctor, I think mother of a doctor, treated as severe asthma, not responded, ABPA treated, ATT not responded, but X-ray gave a clue that it is something serious problem. Underwent bronchoscopy, showed a large growth in the carina, infiltrating carina, and also extending to the both proximal right and left main bronchus. Underwent biopsy, this patient had a clinical examination, they showed nodes, biopsy, adenocarcinoma, stage 4, metastasis, lost life 4 months later. So that is the problem with, these kind of patients in whom that we treat asthma as, we treat label as all wheezing at asthma, especially those patients who are not responding. Unfortunately, this patient is a real mother of a doctor, young, died within 4 months of diagnosis because it's stage 4. There are other differentials that could come to a patient who has a wheezing, could be a vocal cord dysfunction. This is how the vocal cord looks like, anterior and posterior commissure normal, but on patients with vocal cord dysfunction, you see approximation like this. So need not be asthma, something this patient requires a counseling that should suffice for this patient. This is a laryngomalacia that can also mimic like asthma, and you see the normal epiglottis, and this is different in this patient. On the left side is laryngomalacia. This sometimes we see when we do bronchoscopy. This is the posterior wall, anterior wall, lateral walls of trachea, and posterior wall crossing more than 50% of the wall. Tracheomalacia, wheezing, and this responds to CPAP therapy, not to the bronchodilators. This is a case of tracheomalacia, misdiagnosed as asthma, responded to CPAP therapy, not to bronchodilators, and patient is doing well. So what are the disorders associated with and confused with asthma? And again telling you this is not the complete list. These are small list, but commonest list. And look at the factors which are associated with asthma. Could be vocal cord dysfunction, COPD, allergic bronchopulmonary aspergillosis, Stokes syndrome, and so many. The diseases are described in text. Diseases are described in the patient phase, and it is up to the clinician to pick up those subtle signs and to work up. And in India, any patient who has an asthma should be worked up for allergic bronchopulmonary aspergillosis. And we have, the Indian criteria, Dr. Ritesh Agarwal criteria, my beloved friend, currently is a world authority on ABPA, currently the professor of the pulmonary medicine at PGH Chandigarh. So any patient who has an asthma should undergo ABPA evaluation, which is not being done. One of the cause for, reversible bronchiectasis is ABPA. And what are the diseases are not confused with asthma, BCD, COPD, panic attacks. We had a patient today, and bronchiolitis obliterans, CCF, AC inhibitors use bronchiectasis, hypersensitive pneumonitis, pulmonary embolism, eosinophilic syndrome, and so many in the list. So many names. And I'm telling you, believe me, the half of the patients we saw today in our OPD today like this. And look at this patient, 56-year-old male smoker, recurrent wheeze and cough, labeled as asthma, but things are slightly different. Age, smoking history. Look at the factors which are commonly gets associated with that. So look at the CT. There is extensive central or emphysema, both sides. This is a case of COPD. And you might wonder, what is a big deal between asthma and COPD? There is a big deal. Both diseases are different. Unstable angina is different. Non-ST elevation myocardial infarction is different. ST elevation myocardial infarction different. Approach is different. Treatment strategies are different. You give something to this category, something you will not give to other category. COPD is different. Asthma is different. But you see commonly, this patient has COPD. And one day, once it is labeled, it is difficult to remove from the patient file. I emphasize that the history is taken properly and the diagnosis is labeled properly, so that follow-up becomes very easy. The treatment strategies are totally different between COPD and asthma, and we have national guidelines also. So I'm fortunate to be the guideline committee members for these national guidelines. So look at this other patient, elderly male, came with recurrent wheeze and recurrent cough, treated as asthma. But this patient had crackles, coarse crackles. X-ray showed multiple cystic lucencies, multiple stunted, both sides. You can see thin walled, cysts, innumerable, bilateral upper, mid, and lower zone. This is extensive bronchiectasis. This patient had a pan-digital clumping, profuse amount of sputum, early morning sputum, 3-layer sputum, so many which are described in the text. So this is bronchiectasis. There is secondary infection. You can see air fluid level. It is not asthma. It is bronchiectasis, bilateral, extensive, acute exacerbation. So this is a case of bronchiectasis, misdiagnosed asthma, and treated for long time. Look at this 70-year-old lady, follow-up case of bronchial asthma for 20 years on regular medications, admitted with bronchial asthma exacerbation, treated but continue to have symptoms. So believe me, this patient documented bronchial asthma, diagnosis is correct, previously treated well, responded well, and well-controlled asthma. And there is different meaning for poorly controlled asthma, partially controlled asthma, well-controlled asthma. Because of lack of time, I will not go into those details. This was a case of well-controlled asthma, treated but continue to have symptoms. So in medicine, one patient can have many additional diagnoses. One patient can have kidney cancer along with prostate cancer. You can have laryngeal cancer with lung cancer, and you can have any number of differential diagnoses in a given patient. So this same patient not responded to treatment for asthma exacerbation. X-ray looked deceptively normal. X-ray deceptively normal, and symptoms persisting, something else is going on. This patient underwent contrast CT chest, which showed thrombus in both right and left main, the trunk distally, as well as in the segmental branches. Asthma, pulmonary embolism can present with asthma. Acute pulmonary embolism. Yesterday also we had a patient. So this was a patient, pulmonary embolism associated with asthma, and because of some other factors, that patient developed asthma at the pulmonary embolism. And reason for acute exacerbation asthma is acute pulmonary embolism and not perceived due to disease exacerbation. So to emphasize, we need to look into other differentials in a given patient. You can see the thrombus almost every segmental artery. So this is a patient with bronchial asthma PTE present with extensive wheeze. This is a 9-year-old female child presented to us with 2 months history of shortness of breath, fever, cough, mucoid sputum, no other complaints. and no other systemic or CTD complaints. Young child, 9-year-old female with recurrent breathlessness. So X-ray shows bilateral the mucus plugging on both sides. This is not tuberculosis. This is mucus, the hand glove appearance on both sides, more on the right side, less on the left side, and more on the left lower lobe. So this is it's a X-ray itself shows bronchiectasis. X-ray shows there is mucus plugging. So there is bronchiectasis, mucus plugging, allergic bronchopulmonary aspergillosis is the leading diagnosis for this X-ray. And this is after treatment. You can see the X-ray which was taken sometime later shows florid bronchiectatic changes without mucus plugging in the same X-ray. And you can see the sagittal window of CD chest of the same patient shows mucus bronchogram with the distal collapse. Distal collapse you can see very well. So this patient was worked up, had bronchiectasis, young child, 9-year-old female. What could be the cause? So underwent evaluation, finally turned to be cystic fibrosis. Delta 508 mutation was the positive, and this patient had recurrent pancreatitis at childhood, and sweat chloride test is also positive. Now the child is on management for cystic fibrosis. Less common in South India, more common in less common in India, but less common in South India, more common in North India. Already Institute has the registry on the cystic fibrosis under Dr. Kabra at New Delhi. So this is a middle-aged lady treated as severe asthma. I've told you sometime before what is the definition of severe asthma. Did not respond, and you can see it's always a good habit to look into the airways in asthma. This patient came with severe asthma. X-ray showed the diagnosis. There is distal left main obstruction. There is hypertensive lesion on the distal left main bronchus. And CT is just to confirm what you have seen in the X-ray. Tuned what mind does not know, eyes will not see. Eyes will see what you want to look for in severe asthma, and that's where here it is. Tumor, the left main bronchus, growth. This patient presented with asthma-like symptoms, diarrhea, wheezing, flushing, facial flushing, and diagnosis lies there. There is an obstruction, asthma-like symptoms. It is carcinoid, even with history. Look at the PFT showed moderate obstruction. Underwent bronchoscopy showed a globular growth, smooth appearance in the left distal main bronchus. Biopsy showed carcinoid tumor, underwent resection. This patient had carcinoid tumor with carcinoid syndrome mimicking like asthma, and totally different diagnosis. Treated asthma, did not improve. Treated the tumor, lobectomy, patient became normal. So that was a difficult to treat asthma case. Look at this 70-year-old male, diabetic, recurrent wheeze, high eosinophil count, and ONCA negative. CD chest showed bilateral fluffy GGOs, dominantly in upper lobe areas, less common in lower lobes, but still subpleural dominant. So disease presentation pattern where it appears gives differentials in medicine, likewise here also. So subpleural GGOs with high eosinophil count, ONCA negative. So worked up, treated, turned to be eosinophilic asthma. This is one of the important, interesting disease in pulmonary diffuse laryngeal disease, which melts with steroids. This is eosinophilic pneumonia. Follow-up chest X-ray after steroids, it gone away. So likewise, the acute hypersensitive pneumonitis is also very important diagnosis. Day before yesterday, we had a patient with acute hypersensitive pneumonitis. Patient comes with breathlessness, cough, wheezing. It is important to look into the occupational history in medicine, especially very important in patients with pulmonary diseases, because it gives you the diagnosis. Patient presents acute asthma-like picture, and this is the head and cheese appearance. Of classical the acute hypersensitive pneumonitis. You have GGO, septal thickening, and the air trapping. This is acute HB. This patient had a grain dust exposure at milk. Following that, they developed acute breathlessness, and it was HB and improved after treatment. This is a typical head cheese appearance. We call it as in CD thorax. So this is a patient with subacute hypersensitive pneumonitis. This patient was treated as miliary tuberculosis. Because you see the thickening, small nodules, and so many. But this was soft nodules, central lobular nodules, bilateral, diffuse, apex to base, with history of exposure to the dust, the organic dust. And this patient, one of the important history that these patients might be giving, like Monday morning fever. Whenever they go to the work, they develop symptoms. In weekdays when they are off duty, they have less symptoms. This history is very important. Looks very simple. Patient used to say very casually, but it's up to us to catch and those history and to clinch the diagnosis in given patient, because just removing the patient from the exposure, you treat them and also you diagnose them. You diagnose them because untreated, the unattended to the history leads to chronic obstructive pneumonitis, which can be catastrophic fibroid disease, becomes a transplant candidate later on. So this is a patient of subacute hypertensive pneumonitis improved later. Look at this 30-year-old male, asthmatic since childhood, came with fever, worsening breathlessness, wheeze, cough, loss of weight and appetite. So points here are, this patient has fever, loss of weight, so it is more than asthma. So that's the clue it gives in history. So that's why, if you look at the Hutchinson, it says that history is very important. In the preface, they used to write, history taking is very important. With that, you diagnose more than 90% of disease. 99% you diagnose after general examination. That is why you have this short case concepts and history concept. And in our medical schools, they thrash us at the end of chief complaints presentation. So these are very important. These are very important look into to interpret in given patients. Any patient with asthma, weight loss is something serious, and some says that's more than something else. So this today also we had on patient known to me came with wheezing, asthma, proven, improved previously, now came with the fever and weight loss, actually had a right lung mass, and she is undergoing evaluation today. So this patient, 30-year-old male, treated with antibiotics with course of steroids with partial improvement. As habit, this patient was treated with ATT, no response, and they thought it is resistant TB or difficult to asthma and refer to us. And they look at the X-ray. X-ray gives you diagnosis. All white shadow are not tuberculosis. I've told you sometime before, short while before. This is typical. The hand and glove appearance, mucus plugging in the lines of bronchus. So this is allergic bronchopulmonary aspergillosis. You can see bronchiectasis, mucus plug nicely. The impacted there. This patient, because of acute respiratory failure, underwent bronchoscopy. We started removing this mucus. Patient improved. This is the X-ray after removal, and respiratory failure improved. Became off ventilator. Went home with steroids with the diagnosis of ABPA. It is an ABPA complication in a patient with asthma. ABPA is one of the cause of hemoptysis in patients like this. This 13-year-old girl came with episodic cough and breathlessness. Diagnosis of asthma on treatment with bronchodilators. This patient had non-pulmonary symptoms. So lung is a peculiar organ wherein systemic disease picks up many of the times. You can have an SLE in lung. You have a rheumatoid arthritis lung without, even today we have a patient rheumatoid in the lung without being manifestation elsewhere. So if a patient has especially non-pulmonary symptoms with a pulmonary diagnosis, always better idea to look into whether this patient has systemic disease, because lung is not a monopoly, it is a part of body. So any disease can occur as a part of systemic manifestation. This 13-year-old girl had macropapillary rash on the feet and hands, and there is loss of sensation in the feet, and there is increasing breathlessness, not responded to treatment, and there is rhonchi, pansystolic murmur and mitral area, muscle wasting. Diagnosis over. This is systemic disease, vasculitis. In the history and physical examination itself, what else you need? You need tests to diagnose what you have thought. This patient had 32% eosinophils, and ANCA ANA is negative, CPK is normal, PFT moderate obstruction, nerve conduction study claims that there is neuropathy, and this patient had LV dysfunction. You can see the small heart became large heart, maybe kind-hearted, but this patient had Church-Strauss syndrome, small vessel vasculitis, improved with steroids and immunosuppressants later. This patient came to us with a diagnosis of persistent asthma. Chest X-ray was not done previously. Persistent asthma, wheezing, very simple diagnosis. This patient was a carpenter working with this, working with this clips, and the X-ray showed this interesting finding. Later we showed this, and these are the T's and impacted there. So he was working, looking at the roof. It slipped into the bronchus. We did not notice. Had wheezing, was given bronchodilators, steroids. Any step 5 treatment did not improve. Simple chest X-ray diagnosed it that it is not asthma. It is something else. This is a very interesting case which I like. You also like. I think at the end of the presentation, young female came with history of whistling sound. This patient got engaged, and she was talking to her boy, the fiancé, over phone. And that the other side guy, was telling every time, why are you whistling when you talk to me? Are you nervous? But it's not nervousness. It is a medical nervousness. This patient came to us with this history that I spoke to my fiancé and he is telling that I am whistling whenever I talk to him. And X-ray, it clicks the diagnosis, and there is left upper lobe collapse. You can see here, and we are curious to know what it is, why there is specific whistling sound, especially when she got engaged. So CT thorax showed, the some interesting foreign body in the left main bronchus, and underwent a bronchoscopy, and it was pen cap, which was unnoticedly went to the left main bronchus, and fortunate to produce a whistling sound, especially at the time of fixing the marriage. Underwent foreign body extraction, whistling, the pen cap, whistle sound producing material removed, no whistling sound, and I think that girl went ahead with the marriage. So look for factors contributing to symptoms and exacerbations and poor quality of life is very important. Incorrect inhaler technique is extremely important, cannot be emphasized. It itself is an important talk for hours together. So importantly, you have to look into the inhaler technique are very, very important. Suboptimal adherence is, these two things are very important. Look at the comorbidities and modifiable risk factors, which I have discussed previously, and look at the supracortical problem, as we call, and medication side effects and so on. So these are the important factors that should be looked into in any patient with a difficult asthma. Majority of the time, it will become easy to control asthma. There are many devices. If you go to the shops, you see different clothes. You, at the end of the day, you get confused which to buy. And likewise, in the management of asthma, you have different devices. All devices are good. Which devices patient likes is the most efficient device for the patient. So this list is not complete. There are many more. So that confuses in patient management, which is best. None of the thing is superior. Which the patient likes is superior to that patient. So look for comorbidities and look for them, treat for them in patients with asthma is very important. COPD, respiratory infections, other APPA, bronchiectasis, OSA, obesity, chronic sinusitis, and so on. There are many lists. Any patient, if you look at recently, there is COVID pandemic, that if you look at the past history, there are a lot of diseases for that patient. Likewise, asthma patient can have many, especially that should be looked into whenever the patient is not responding to treatment. Optimizing a treatment is very important. Asthma education is important. Optimize the treatment, I cannot overemphasize it here because, there's lack of time and it's not a talk also. So optimizing treatment is very important. Look for comorbidities and modify risk factors and appropriately change the medical management so they will improve. And whether this patient has controlled asthma, uncontrolled asthma, just divide that. Look for response for 3 to 6 months, and likewise you can step up or step down therapy. And if the patient is not responding, you look into all the factors which I projected sometime before, and you have to phenotype this patient whether there is type 2 inflammation dominant or type 2 inflammation not dominant. Depending on that, you can choose medications for IL-5, IL-4 receptors inhibitors, anti-age therapy, and so on. I will not go into those details because the lack of time, and this is not a topic. So what the point I want to emphasize here is, these are therapies available once you rule out all the difficult factors which we have discussed sometime before. So always once you start, you have to review the response, whether the control is there, whether there is no exacerbation, lung function is okay. That means you have done your job. You continue the optimizing the treatment and follow the patient every 3 monthly. So that's where it lies. So to conclude, difficult to asthma is a challenge for patients and physicians especially. So look into the factors which we have discussed sometime before. Confirm the diagnosis of asthma. A systematic approach is needed to manage these patients. Very important. Check the inhaler technique and complaints. Check the inhaler technique and complaints. Check the inhaler technique complaints is important. If this point goes out of this talk, I will be very happiest man today in this world. Consider different comorbidities which may worsen the asthma is very important. Consider different phenotypes being recognized in severe asthma. Look beyond lung for causes of worsening, especially you have a patient with difficult to asthma. Thank you for the patient listening. Happy to take up any questions if there are any. Over to Dean, sir.
Thank you, Dr. Loganathan. Any questions from the audience? You're welcome.
Thank you, sir.
I think hereafter this consultants giving lectures, instead of talking theory, they can present cases like this. Both presentations were interesting and self-explanatory. That's why, I mean, audience, they do not have any doubts, I think.
Sir, what way we have to prevent this asthmatic?
Sorry, sir, I'm not getting your question. Please.
Yes, I am Dr. Arunagar from Ganapati, sir.
Yes, sir.
Yes. So how to prevent the asthmatic, sir?
How to prevent asthmatic
Yes.
attacks?
How to prevent asthma?
How to prevent asthma? No. See, your question is totally different. So, how to prevent this asthma? Is like any other the primary prevention that comes under primary prevention. You avoid exposure to dust. You avoid the antigen exposure. You avoid those factors which can contribute to hypersensitivity pneumonitis, the chemical exposure, and so on. So, the talk
Sir.
today is how to prevent difficult to control asthma or severe asthma. But if you ask the question that how to prevent asthma, I think it's mostly environmental control. Hope I answered your question. So it is dominantly, as far as asthma is concerned, how to prevent asthma is to mainly the environmental control.
Yes. Thank you, sir. Thank you so much.
Yeah.
If there are no questions, then I think we can close the session. I thank Dr. Murugesh and Dr. Loganathan, who have obliged to our request for participating and delivering today's lectures. And I thank all the senior consultant colleagues and doctors from Ramakrishna Hospital and also from the city of Coimbatore. Once again, I thank all of you, and we'll hopefully meet you all in the next webinar. Thank you.
Thank you, sir. Thanks.
Thank you, sir. Thank you, sir.
Thank you.
Thank you, sir.
Hello.
Thank you, sir.
Sir.